Okay, so best practice in this for the medical patient, use the least amount of intervention necessary to accomplish your airway objectives given the patient's needs. Meaning if you can get by with a nasal cannula at 2 liters per minute, then a nasal cannula at 2 liters per minute is where you stop. If you have to progress all the way through intubation due to respiratory failure, then you proceed all the way through to intubation. End-tidal CO2 should be used on all critical patients and when it is necessary for a clinical diagnosis. So end-tidal CO2 is going to give you your best indicator of ventilatory status of your patient. It gives you a breath by breath, real-time indicator. End-tidal CO2 must be continuously monitored from the onset of manual ventilations with or without an advanced airway. So if you have to breathe for this patient, if you're using the bag mask ventilations, from the very first breath, you should have the side stream attachment attached to that bag mask from the first squeeze of the bag, with or without an advanced airway, meaning whether they're intubated or not, you should have end-tidal CO2. It will work with a bag mask setup. End-tidal CO2 is to be placed prior to the first breath with an advanced airway. Advanced airway being an LMA, an ET tube, that sort of thing. So it is to be placed prior to the first breath given through a advanced airway. Well, if we're following our best practice, we already have it attached to the bag mask. So it's already in place and you've got a good indicator of your ventilatory status. Also, SaO2 values tend to lag behind hypoxia, behind actual hypoxia. Pulse oximetry values tend to lag approximately up to 2 minutes behind what the body is actually doing. This is good for trending, and end-tidal CO2 is good for immediate indicators of status.